Here we go. So, welcome to our webinar, which is specifically for the Stickler community. If this is your first time participating in one of our events, we welcome you with open arms. I know that many of you were on our previous Stickler webinar, and we welcome you back to one of our programs again. As you know, today's presenter will address the eye issues of Stickler syndrome and how to treat them. There will also be plenty of time to answer your questions. Please put them in the Q&A box, not the chat box, and keep them general rather than sharing all your personal medical history or your child's history. If your questions are not answered tonight, then you'll be able to submit them to us through marfan.org/ask, and I'll put that URL up a little bit later. Stephanie, who is our Help and Resource Center Director, and her team will get you the answers. And now, to tell you a little bit more about Stickler and the Marfan Foundation, here's Michael Weimer, our President and CEO.
Thanks, Eileen. Good evening, everyone. It's great to be on the second event of this type. You know, we really couldn't be more excited to see the community enthusiasm and also the early engagement of the Stickler community members. It's really been very gratifying. If you're new to the foundation, the last few years, the Loeys-Dietz Syndrome Foundation and the GenTAC Alliance, a global science arm, joined the foundation. And we also created the VEDS movement 5 years ago. And that's now the leading VEDS organization globally. Truth is, the Stickler community can be anything you collectively work to create. And our team, led by Eileen, naturally, is here to help. We would love to support this group in creating the new version of the Stickler community. And we were also surprised when we learned that 1 in 7,500 people have Stickler. We had no idea that incidence was that high, which presents, I think, great opportunities for community engagement and efficient physician involvement as well. I mentioned before we got started that we have our 40th conference coming up July 10 through 13 in Atlanta. Eileen will be chatting about that later, and you'll see some information on how you might register. We would love to see members of the Stickler community join us. There's usually upwards of 800 individuals at the conference every other year, and we're expecting that same kind of attendance this year. And as I mentioned on our last get-together, if there is enough engagement and a critical mass, you know, Eileen and I we'd welcome the opportunity to host a cocktail or a reception for the group. So please keep that in mind. With that, I'm going to turn it back to Eileen to introduce our terrific presenter. Eileen?
Great. Thanks so much, Michael. So now I'd just like to invite our speaker, Dr. Cagri Besirli, who's an assistant professor and the Skillman Research Professor in the Department of Ophthalmology and Visual Sciences at the University of Michigan Medical School. He is a clinician scientist and has dedicated his career to improve vision in children and adults with retinal disorders. Dr. Besirli specializes in diseases and surgery of the retina and vitreous, as well as management of acquired and inherited pediatric retinal disorders. His laboratory research focuses on modulating retinal metabolism to identify novel targets for ocular neuroprotection. I think he's probably going to tell us what that all means in the next little while. Anyway, so now I just want to pass it over to the doctor for the presentation.
Thank you, Eileen, and thanks everyone. I just want to start with thanking everyone who are joining us online today, and a special thanks to both Eileen and Michael for giving me the opportunity to present today. So I'll go ahead and start sharing my slides. Okay, Eileen, can you guys see this?
Perfect.
Okay, perfect. All right. So in the next probably 20-25 minutes, I like to go over some of the eye issues that might be experienced in patients with Stickler syndrome, and then hopefully we'll have plenty of time to answer some questions. Just a quick overview of what we're going to talk about today. First, I will give you a little bit of a introduction of Stickler syndrome, you know, from an ophthalmologist viewpoint. And then I will go into some of the issues that I've certainly seen on my patients' experience, including myopia, glaucoma, and retinal detachment, and we'll go into much more detail about these. So to start, the Stickler syndrome is one of the hereditary arthro-ophthalmopathies. You know what that means. What's in the name is that arthro meaning joints, ophthalmopathy meaning the eyes. It's a disorder of the joints and the eyes. We know, of course, it has more than that, but initially that's what it was described. And it's an inherited disorder of collagen, as Michael mentioned. The incidence is about 1 in 7,500 births. And it typically is it's an abnormality in type 2 collagen and specific genes in collagen, and we'll go into that in a little bit. In terms of what we see, you know, as systemic findings in impacting the entire body is these, you know, Stickler patients can have premature arthritis. They have skeletal changes. Some can be diagnostic. That we look for, you know, typically when we have patients present to us who are suspecting Stickler syndrome, we do look for some of those changes. And then deafness is something that can be, you know, presenting in patients with Stickler syndrome. What we will focus on is the ocular manifestations. And then in you know, what we see in patients with Stickler syndrome is high myopia is one of them. It's nearsightedness, very, very nearsighted eyes. Glaucoma, which is increased eye pressure that can lead to damage of the optic nerve. Cataracts and retinal detachment. And what we know in the ophthalmology community is that the Stickler syndrome is the most common cause of inherited and childhood retinal detachment, and that's very important. And I will discuss more of that as we do have some ways to prevent and or reduce the incidence of retinal detachment in patients with Stickler syndrome. In terms of the genetics, there are multiple types of Stickler syndrome from type 1 to type 6. The most common are the first type, the 3 types, type 1, type 2, and type 3. And type 1, which is the collagen 2A mutation, is the most common of all of them. And the type 2 is collagen 11A1 mutation. Both type 1 and type 2 have manifestations in the eye. They can present with eye disease. And type 3, which is a collagen 11A2 mutation, does not affect the eyes. And we won't really go into type 4 to 6 because these actually happen to be quite rare. So most patients, and then you know the you know people in the audience, that you know the families or the you know your friends that you might know with Stickler syndrome probably had the type 1 or type 2 disease. Um, we do recommend, in most cases, if not all, genetic testing to confirm diagnosis, and which can actually guide our treatment recommendation. Genetic testing is important to determine if retinal and or systemic problems may occur and should be screened for or treated. With the correct genetic diagnosis, we can certainly make referrals to the different subspecialties that potentially may have recommend screening or treatment options. We can understand the prognosis based on some of the genetic mutations, and as well as discuss treatment options. The other important factor for genetic testing is to really establish risks to relatives. You know, we can confirm the pattern of inheritance. Is it autosomal dominant, autosomal recessive? Typically, it's autosomal dominant. Allow for genetic testing, you know, genetic screening in other family members. And the question always comes up, you know, when do we genetic testing? So typically, you know, in my experience, you know, if we have a number one is if we have a family history of Stickler syndrome, we know that's one reason to consider genetic testing. If we see in my practice, if we see a child with ocular changes, eye findings, and as well as other skeletal findings that suggestive of Stickler syndrome, we do typically consider genetic testing. Or, you know, often what I see is that I saw a child who with retinal detachment, which is quite unusual event in a child. We typically consider Stickler syndrome as high on our list of potential diagnosis, and often we'll recommend genetic testing to confirm that if other findings support that. Now we'll move on to talking about the eye. So some of you may be familiar with the eye, some of you may not be. So I just want to first go over the anatomy of the eye. So we're you know we have a we all kind of understand and what you know what part of the eye that we're discussing. So if you can see this, let me see if I can get a laser pointer. There we go. So hopefully you can see my laser pointer, and you can see this is the eye section in half. And in terms of the anatomy of the eye, the front of the eye, where we start with the cornea, that's the clear part that lets the light in. Then we have iris, the color part of the eye, the lens, which is clear in when we're young, and then slowly becomes cloudier and forms a cataract as we age. So this entire part from lens to the cornea is the front of the eye, or anterior segment. So that part is involved, is involved in some patients in Stickler syndrome. Now, behind the lens, we have vitreous. That's a part of the eye that's essentially a clear fluid that allows the light to go in without interruption. And then the inner wall of the eye is covered with a tissue called retina. And retina is really where the light sensing cells are located. When the light hits those cells, it triggers a reaction, and that forms vision, which is then transmitted from the retina through the optic nerve. That's the cable that carries the vision from the eye to the brain. So this is the posterior part, back of the eye, or posterior segment. So anterior segment, lens to cornea, and posterior segment of vitreous to retina to optic nerve. Now, the reason I'm mentioning this because we're going to talk about different manifestations of Stickler syndrome affecting the front of the eye or the back of the eye, as the Stickler syndrome can actually impact the entire structure of the eye from front to back. Now, just to kind of get a little bit of more idea of the anatomy here, let me see if I can play this. Oh, I might have to turn off my laser pointer. Give me 1 second. Okay, so just to look at the eye again, and in this video again, you can see the front of the eye where the light comes in from the cornea, and then the pupil is really that opening in the color part of the eye, the iris, and then the light goes through the lens. Some patients with Stickler syndrome may have cataracts that can impact the light traveling into the eye. And then it goes through vitreous, this clear part, to hit the retina. And the retina actually has multiple parts. And the most important part is the macula. That's what we use for sharp vision, reading vision, driving vision. And the peripheral retina, which we use for more peripheral vision or dark vision. And most of the pathology or the issues that we see in patients with Stickler syndrome happen in the peripheral retina. And then finally, we have the optic nerve that, again, carries vision from the eye to the brain. And then one aspect of the Stickler syndrome can impact the optic nerve, which can damage, if we have a damage to the optic nerve, that can impact your reading vision as well as your entire visual field. Now, the first issue that I wanted to highlight is myopia or nearsightedness. This is extremely common in patients with Stickler syndrome. So what is myopia? Most of you probably know what myopia or nearsightedness is. Most of you probably are wearing glasses or have worn glasses in the past. So the normal eye, when the light comes in, the focal point of the light is right on the macula here, the central part of the retina. And the myopic eye is typically a longer eye, so the focal point actually ends up being in front of the macula, and what that does is that it causes blurry vision, and that needs to be corrected. So myopia could happen because the eye is longer, which is called axial myopia. There are other reasons why someone can be myopic or nearsighted, but most common especially in Stickler syndrome is that the eye is longer. Now, how do we treat myopia? We have glasses. Typically in young children, glasses is the first option before they're old enough to wear contact lenses, which can be tried. And also there's refractive surgery, like LASIK surgery, that can be considered. Now, LASIK surgery is definitely an option, but there are certainly some considerations that may make some patients not necessarily good candidates for refractive surgery, depending on the anatomy of the eye. In terms of the glasses, the treatment, the treatment is important to prevent amblyopia. And what I mean by that is when the eye doesn't have the correct the right correction, and if the vision is blurry, in young children, that can cause the brain not to develop the visual cortex of the brain, not to develop correctly, and that leads to a condition called amblyopia, where you have less than ideal vision. So the most important part of correcting the vision, especially nearsightedness, in patients with sticklers, is to really to diagnose it as quickly as possible and correct it as young as possible. The younger we intervene and correct nearsightedness in patients with Stickler syndrome, the more successful the treatment is going to be. Now, another question that comes up often in patients with Stickler syndrome, and especially the families I work with, is that a lot of the Stickler syndrome patients have high myopia. They're very nearsighted, and there's always a concern that myopia is going to progress and it's going to get even worse. Now, we've asked this question actually as a research question with our collaborators. We looked at our patients, and then our finding was that actually the myopia in Stickler syndrome patients is typically not very progressive. It does progress, but not to a great extent. So if you look at this, if you look at this graph here, actually what you see is each line is an individual patient, and we follow them up to about 10 to 15 years. And you can see that most patients, they're essentially a flat line. After some changes in the beginning, there's a flat line, meaning that their refraction, their glasses correction actually is not changing very much. So, but also, if you look at actually this side of the graph here, it goes from 0 to -30. It also tells us that a lot of these patients are actually around -10 to -20, which is very high correction and very high myopia. So the patients typically have high myopia, but and often it's not very progressive. So the refraction stays stable. So the mean change in our study was about -2.4. So that's given a lot of patients are around -10, -12, -15. That's actually a small amount of progression over many years. The next eye problem that I wanted to discuss is glaucoma. What glaucoma is actually there are multiple types of glaucoma. And the one type that I wanted to discuss with you today is the glaucoma that is secondary to increased eye pressure or ocular hypertension. Just like increased blood pressure, you can have increased high pressure ocular hypertension. In a normal eye, the fluid is made in the front of the eye, the anterior segment, as we discussed earlier, and then it goes to the front. It's made between the lens and the iris, and circulates to the front, and then is drained from the front of the eye. And this fluid is important to keep the normal pressure in the eye itself, which typically the normal range is anywhere from 10 to 21 millimeters of mercury. In a patient with glaucoma, what happens is that either the production increases or drainage is blocked, which then disturbs the normal homeostasis of this fluid. And so instead of fluid, this concentrated, fluid production and drainage, now you have buildup of fluid, which increases the eye pressure. And then that leads to the increased eye pressure eventually can lead to a condition called glaucoma. Increased eye pressure itself is not glaucoma, but untreated increased eye pressure can lead to glaucoma, which is a damage to the optic nerve. And why is that important? Because damage to the optic nerve could mean that the visual field, your entire field of vision, can actually start develop blind spots, or can get constricted. So that's something that we definitely want to prevent. And the way we do that is the treatment of glaucoma is there are multiple options. We can use eye drops. This is the first line of treatment. So you might actually be using drops yourself, or you might know people who do that. And we have multiple options for different eye drops we can use. And the selection of the eye drop also depends on the age of the patient. For some younger patients, our options may be limited, and older patients, we have more options. If the drops are not quite adequate to control the eye pressure, to get it to a level where we think it will no longer damage the optic nerve, we can use oral medication or pills. Typically, these are used short-term. They're not long-term treatments, but we can use them short-term to kind of get everything under control. Now, medical therapy using eye drop or pills, if they're not sufficient, or what we typically will say maximum medical therapy, if that fails, we have other options like laser surgery, where we go in actually and we can we can, with laser therapy, we can increase the outflow of the fluid by lasering the area that allows the fluid to escape the eye. And if that doesn't work, we can do incisional surgery. Now, this would require going under anesthesia, and then and this is a full-blown surgical procedure where we go in and we put essentially a drainage device that communicates from the outside of the eye to the inside of the eye with a tiny tube, and that tube will actually allow the fluid to drain and normalize the pressure. Now, glaucoma, the vision loss secondary to glaucoma can be very slow. So most patients actually don't notice a change for a long time until they have a pretty significant visual field defect or loss of vision. But it's, but this vision loss could be quite serious without timely treatment. So this is something that we always monitor in our patients, their eye pressure when they come to clinic, and then making sure that we have reliable measurements, we repeat them, and if we start seeing the pressure creeping up or staying, and starting at a high level and not coming down, we start considering treatment options for that. Again, the sooner the treatment, the more successful the outcome for glaucoma. Now, I want to spend a fair amount of time on retinal detachment. The reason for that is this is, again, as I mentioned earlier, Stickler syndrome is the most common cause of childhood retinal detachment. And retinal detachment itself can lead to severe and irreversible vision loss. And often these patients present at young age with retinal detachment, which is quite unusual. Most retinal detachment actually happens in older adults. So when we have retinal detachment in a child, and especially if it's not in the setting of trauma, we're considering some underlying conditions such as Stickler syndrome. And the reason for the importance of detecting the retinal detachment or preventing it is that unlike adult retinal detachments, retinal detachment surgery in children is not the success rate for retinal detachment surgery in children is not as high as adult retinal detachment surgery. And in children, multiple surgeries may be needed. What I tell our families is that typically when we have a child with a retinal detachment, really kind of need to be ready for multiple surgeries because sometimes we have to stage the surgery. And typically there might be a scarring reaction that the kids have a much more robust scarring reaction that can lead to redetachment of the retina. So, typically, we are ready for multiple surgeries to stabilize the eye, stabilize the retina. This is where we actually recommend preventive treatment because for some patients, preventive treatment may be available, and that can reduce the rate of retinal detachment significantly. So what the picture is showing here is the retina, and this is a real human retina here. And there's the optic nerve that what we talked about. That's the cable that carries vision from the eye to the brain, the blood vessels. And this is the macula. That's the part that is the most important part in terms of reading, sharp vision, color vision, and the peripheral retina. Typically, when the retinal detachment happens, it happens in the peripheral retina, as in this case, and then you get a large tear or a rip in the retina, which allows the vitreous fluid to kind of seep back in and then and sort of essentially detach the retina. And once the retina is elevated with fluid behind it, its functions decreases. Its function decreases over time. And if it's not repaired immediately, the cells that detect light eventually will die, and that loss is irreversible. We can't bring them back. Now, how do we treat the retinal detachment? So I have another sort of video here to show that to you, and then I'll talk about it a little bit. So typically, the most common treatment for retinal detachment is a surgery called vitrectomy, which this video is going to show, or a scleral buccal surgery. And sometimes we'll do both of them, but we'll talk about vitrectomy. This is the most common procedure performed. So what happens is that what we do is with little sort of metal tubes, we can put our instruments into the eye. So this is a light. This is all done under a microscope, a surgical microscope. And we go in and we start cleaning out. In this case, this is not in this case, there was some blood in the eye. So we clean the blood. And after that, we can go in and repair the detachment. We can do some laser treatment. So this is called a vitrectomy surgery. But okay, so before we move on to this one, I just want to give everybody a warning. So the next going to show a real surgical video. So if you're going to see an eyeball under surgery, so if you this is something that not everybody is maybe interested in watching, so you might want to turn away or close your eyes for this part. So this is actually one of our surgeries. Again, this is just for illustration purposes here. This is another type of retinal detachment surgery we do. So what we do is, this is all done in the operating room. Most patients, who require the surgery are children, in my experience. So of course, for children, we have to put them to sleep under general anesthesia. For adult patients, we can do this under local anesthesia, but typically these surgeries are long surgeries. So general anesthesia is often what we will recommend, to just for the comfort of the patient. And you can see we open the eye with a device called speculum, an eyelid opener. After we cleaned everything and draped everything, and we put these little metal tubes with the blue ring each blue ring is the metal tube, which then we can allow us to put our instruments in. Now we're constantly pushing fluid into the eye because we're going to be removing a lot of fluid. And so to maintain the eye pressure and maintain the structure of the eye, we have to constantly infuse fluid into the eye. So what we're going to do is, we go into the eye again. This is the retina that's detached. There's a lot of scar tissue that's formed, kind of pulling the retina up. Just to orient everybody, this is the optic nerve again. This is the left eye of the patient, and you can see the blood vessels. And then you can see what the surgeon is doing. What I'm doing in this case is removing the vitreous gel, which essentially organized and scarred down and holding the retina up and detaching it. So this is done meticulously. It can take anywhere from 45 minutes to several hours to do this. And then once all the scar tissue is removed, what we're going to do is I'm going to kind of go forward. We're going to remove all of them. We'll use different techniques, and then we go all the way to the end here. And then once we remove everything, what we do is we're going to start doing some laser treatment to repair where the retinal hole, the tears were. We can tack them down with laser, and that'll allow the retina to remain attached. And we fill the eye with an air bubble or a gas bubble. If you know anyone who had retinal detachment surgery, you may have heard this. And then what the patients need to do is they need to position in a particular way for the retina to remain attached. Now, in children, often what we do is we put silicone oil in the eye, and then so they don't have to necessarily have a strict position or requirement, as that's not really possible in a young child. And then what we need to do is that when the retina is attached and the surgical outcome is successful, we would go in a separate surgery to remove the oil from the eye. Now, ideally, we want to make sure the patients don't get to that stage. Ideally, what we want to do is we want to prevent retinal detachment. Now, there is a way that we can certainly reduce the risk of retinal detachment, reduce the incidence of retinal detachment in patients with Stickler syndrome. And the way we do this is we do either laser photocoagulation or laser treatment, or cryoretinopexy or freezing treatment. So the goal is, what we know in patients with Stickler syndrome is that most of the problems happen in the peripheral of the retina. So in this eye model, again, this is the center of the macula, the retina, macula, optic nerve, and the peripheral retina is actually closer to the front of the eye, the anterior segment. So most of the problems actually happen in the front of the peripheral retina. Now, so the picture to all the way to the right is actually the retina sort of in two dimensions again. So the peripheral retina is this part right here. So what we can do is we can actually put laser in the peripheral retina, and we can all the way around, and that what we call prophylactic laser treatment will in fact reduce the chance of detachment by about 60%, based on the literature, what's published in the literature. If the patient has no history of retinal detachment, if they have any history of retinal detachment especially in the fellow eye, it reduces the chance by 80%. So that's what was been reported in the literature. We've actually looked at our own data, our own patients, and with this laser treatment in our hands, we have we're reducing any incidence of retinal detachment is about 80 to 90%. So this procedure itself is extremely successful. It's not 100% reduction, but it significantly decreases the risk of detachment. And in the patients that detach despite this laser treatment, the detachment extent is also smaller. So those eyes happen to be often less complicated surgeries because we already have laser in place. So this is a treatment we do typically recommend for our patients, especially if they've had any history of retinal issues, retinal tears or retinal detachment, any family history of retinal tears or retinal detachment, because we know Stickler syndrome runs in families. So we can typically tell, if the family members have any eye issues, that's more likely that the patient is going to have eye issues. And we can typically tell based on, when the family members have eye issues, like when that might be. Um, Another question that comes up often is like, how soon does this treatment need to be done? Um, our recommendation, my recommendation is typically as quickly as possible. We know the risk of detachment in patients with Stickler syndrome really increases by about, around age 8 or above, but I certainly had patients who are younger than 3 who had, Stickler syndrome and retinal detachment presented with retinal detachment. So as soon as the child is old enough and anesthesia is safe, we typically will recommend doing laser treatment if they fit the criteria of a patient who might benefit from it. An adult patient, it can be done at any time, obviously. Typically what we do is, depending on the patient and then the state, what's happening, with their eye or how their age, we might do both eyes at the same time, or we might do one eye, have them recover, and then come back and do the second eye. For younger patients and young adults, typically we do this in the operating room under general anesthesia, so the patient's comfortable. For adult patients or young adults who can tolerate it, this can actually be done in the clinic setting as well. So that's always an option. And in terms of the, who would qualify for this treatment, the data is really for available. The data that we have available for this treatment is really for patients with collagen 2A1 mutation or type 1 sticklers. So that's the one that we typically recommend it for. So in conclusion, Stickler syndrome may lead to several eye problems, starting at an early age and continuing into adulthood. So my recommendation is if there's any suspicion for Stickler syndrome, we do see an eye specialist, have a comprehensive eye exam, and making sure that if there's any suspicion, consider genetic testing and referral to a specialist. The treatment of myopia, nearsightedness is extremely important to prevent the risk of amblyopia. And checking eye pressure to assess for the risk of glaucoma is very important. And finally, and monitoring for and trying to prevent retinal detachment are very important to maintain vision. We do recommend prophylactic or preventive therapy for retinal detachment, as we find that to be extremely effective. Again, the goal is to prevent the retinal detachment. We can fix the retinal detachment, but we want to prevent it. And genetic testing and is certainly something that we often recommend, as that will determine our essentially prognosis, referral to other subspecialists, and patients with Stickler syndrome, especially if they have eye issues like glaucoma or retinal detachment, they might require multidisciplinary approach and for optimal management. So, it's always a good idea to making sure that your eye, the provider for eye care is comfortable with, evaluating and treating for patients with Stickler syndrome, or have someone that they can refer to if their problems or some issues arise, if they have questions about management. With that, thank you again for your attention, and I'm ready to take any questions.
Great. Well, I just want to say thank you so much for the presentation. In the middle of your presentation or towards the end, my power and my internet went out. So I missed part of it.
I'm
I was
sorry.
scrambling to get back on, but I also lost, I only see a couple of questions here now. I asked you a couple of these, but I don't know if you're able to see more of
I
the.
see. Yeah, I see 18 questions.
Okay, great. Yeah, I only had the last
Uh,
two. So if you want to maybe start at the beginning, and I'm sorry I can't help you. This has never happened before to me. So if you want to just
yeah,
take them
absolutely. Yeah,
and
I'm happy to do
go
that.
through
I
those,
can do
that'd be
that,
great.
Ivan.
Thank you.
Absolutely. So, So the first question we have is, what is your opinion on doing retinopexy on a 2-year-old with confirmed Stickler syndrome, confirmed high myopia, but no retinal detachment? In my experience, I think the sooner the better. So if the child is healthy and they can tolerate the procedure, I would say probably typically, in my practice, we typically do it around 2 to 3, the youngest we would do. So it sounds like, a 2-year-old probably is right around that age that they can benefit from the laser treatment. So if they have the collagen 2A1 mutation, we know this laser treatment works extremely well. So that would be my recommendation to proceed with the laser treatment. Now, if the family has any concerns, you can always consider doing one eye, see how the child recovers from it, how they do from it, and then before proceeding with the other eye. I don't think there's a huge urgency to do both eyes at the same time, as long as, with the understanding that that would require two sessions in the operating room. But again, most children tolerate surgery extremely well and recover very quickly from that. The next question is, it's about, I suffer with an eye issue that most eye doctors are confused with. I know that connective tissue disorders share some of the issues. The whites of my eye looks like they are melting, especially in the mornings, not every day. Okay, and then the whites lay on top of my eyelids. It's not extreme, but very uncomfortable. Yes, so this is not a typical finding for Stickler syndrome, but there are other connective tissue disorders that can certainly affect the white of your eye or the sclera. There are some conditions like Ehlers-Danlos. There's some other collagen tissue disorders that can lead to thinning of the eye wall. That certainly can be an extremely concerning, could increase your risk of having some complications. So if you have an if there's already an underlying genetic diagnosis, or if a condition, certainly there might be some eye specialists around the country you might be familiar with that. If it's a connective tissue disorder, if you haven't been able to if the people you're working with, the doctor you're working with, have not seen it before, I think it's certainly a very reasonable to ask for a referral to a tertiary care center, such as like a university hospital, who might be comfortable, more familiar with actually patients with that condition. So I highly recommend doing that. Is mitral valve prolapse very typical with Sticklers? I won't be able to answer that one. I've certainly had patients with that, but I'm not a cardiologist, unfortunately, so I'm not going to be able to answer that one fully. And let's see. Okay, there's a question about loose eyelids. I think that's again, that might be something that can happen as we age. It's actually not that uncommon, especially it's not associated with Stickler syndromes, but it's more sort of an age-related issue. If the eyelids are kind of drooping down and covering the visual field and making it difficult to see, or if you're kind of using your forehead to kind of lift up eyelids, it's time to consider surgery for that. And the surgery, which is called blepharoplasty, as the person who asked the question stated, is certainly extremely successful, and can actually be done outpatient, and can actually be an office procedure. You may not even have to go to the operating room for that. Which is better for protecting eyes, Tribex lenses or polycarbonate? I do typically recommend polycarbonate lenses. So essentially, most patients I work with are children, and typically, my recommendation for the parents is, just something that the child cannot break. Absolutely. So then again, the most important thing is to wear glasses, so their nearsightedness is corrected, and then patients that have lost vision in one eye due to retinal detachment or glaucoma or amblyopia, they really need to protect their better seeing eye. So it's something that we always emphasize in clinic, especially for children who may not be that super excited to wear their glasses, that they should always have eye protection to protect their better eye. What's the recommended age for prophylactic laser procedure for kids diagnosed with type 1 sticklers? our doctors recommending no action before age 6. So there's really no consensus on this. There are no guidelines on how early. So the studies have looked at it, as I mentioned, is that the risk increases with, as the patient gets to age 8 or above. So certainly anytime before then. Now, if you have family members with Stickler syndrome, and if they've had early retinal detachment, if you can basically use that as an information to see, okay, when they might be at risk, high risk. As I mentioned earlier, we recommend as early as 2 to 3 years of age, because I've certainly seen patients that have retinal detachment or other retinal issues before age 6. But I would say continue to work with your physician, see, in their experience what worked best and what they've seen, and use all that information to make a decision, I would say. Is there any benefit insurance-wise to getting a genetic diagnosis as opposed to being clinically diagnosed? That's a great question. So one part that we have not talked about is that genetic testing may be covered by insurance or may not be covered. We run into this issue often in our clinic. Most insurance companies may not cover genetic testing. If for our patients with Stickler syndrome, typically we do a very sort of focused genetic testing. Sometimes we can even just test one gene, which could be cost effective, especially if there's a family member with that mutation. The reason to get genetic testing, there are multiple reasons. One is that, based on the mutation, we know the prophylactic or preventive treatment, that most of the data is for patients with collagen 2A1 mutation. So if you have that mutation, it's easier for us to kind of explain the results and recommend that treatment. If you don't have that mutation, sometimes we have to have a longer discussion about the risks and benefits of the treatment and unknown potential for benefit, especially. The other reason to get genetic testing is that, if this is the first, member of the family, potentially, if they're going to, you can think of, for family planning for the parents, as well as family planning for the child in the future. And also to really get a genetic diagnosis will help with referral to the pediatric genetics, cardiologists, otolaryngologists, other subspecialties, especially if there's a genetically proven Stickler syndrome, because we know, the other systemic issues are likely in these patients that they can be screened for. Let's see. Is genetic testing indicated if you're an adult with Stickler findings, and no kids if you receive non-genetic diagnosis as your child? It's an excellent question. So if you're not planning to have children, if there are no kids, you're not planning to have, essentially, you're not thinking about family planning. It's really that's a much more of a personal choice, especially if you've been clinically diagnosed and treated already. So, typically, that one is a really discussion between the patient and the physician, depending on your wishes, what the patient would like to know, if the physician thinks that genetic diagnosis is going to change their management or not. So, the answer could be either way. So it's difficult to know without knowing the specifics, but I would say it's something that certainly you might want to discuss with your physician. Years ago, someone postulated that manifestations might be worse if mother passed it down versus father due to mitochondria. Any news on that? My dad's mom had several children blind by age 20. My father passed it to me. And so Stickler syndrome is not mitochondrially transmitted. So there are certainly other eye conditions, hereditary eye disorders that might be mitochondrial transmission. So it's really the manifestations kind of depend. It's really more driven by the gene, the mutation, and then what that mutation, with the function of the gene that's impacted. So it's hard to compare this to there's so many different genetic disorders of the eye. It's difficult to know exactly what the manifestations are going to look like. One of the things I do is actually I treat children with inherited retinal diseases, can be caused by over 280 different genes, mutations, and we see all variations, even in same families with the same mutation. We have patients who have very mild disease, patients who have very severe disease. So it really kind of depends on the genetic mutation itself, and some of the other factors that probably drive the impact on the eye. Eileen, are we doing okay?
Yeah, you're doing great. I mean, we definitely have time for more questions.
Okay. So, okay, so this is a question about what criteria do you most often see where enucleation or evisceration of the eye is appropriate after failed retinal detachment surgery? How often do you see the need for this procedure? Does Stickler syndrome affect the fitting of a prosthetic going forward? Excellent question. So most of what I talked about is to prevent getting to this stage, but sometimes we can't. Even the treatments we have, they're limited. They don't work for everyone. Some patients have severe retinal detachment that we can't fix after multiple surgeries, or their eye react to the detachment or the glaucoma surgery, or it typically can have they may just not recover. They may not fully recover from it, and they may have recurrent detachments that we may not be able to address, which may lead to losing eye pressure, eye getting smaller, essentially complete loss of vision. And then, we sometimes what we do is we consider recommending enucleation. Essentially, what that means is removing the eye, or evisceration is removing the contents of the eye. I don't, thankfully, this is not something that we see often, but it does happen. Certainly had several patients who had to have this. But I would say in the for the spectrum of Stickler syndrome eye problems I see, this is not common, and mostly because we can prevent getting to this stage. But typically, when we recommend this is if the eye doesn't see. So typically, what that means is the eye has no light perception. There's no detection of light, and the eye is painful. So there's bleeding in the eye. That's increase the eye pressure sometimes to a level it might be painful, or the eye pressure actually goes down so low that can lead to pain itself. So if there's the condition is called blind painful eye. So if there's blind painful eye, we do certainly discuss the possibility of this. This is not may not be the right choice for everyone, but it's something that certainly can be considered to provide comfort for the patient. And then in terms of which option to use, complete removal or removal of the contents and prosthesis after that. That is actually an excellent question. It's a long discussion with the surgeon you're working with, what the goals are, what the patient, what the surgeon wants to accomplish, to essentially, for optimal treatment, what the patient would want, and the outcome to be look like, and then really kind of finding that right balance. And then in terms of the fitting of the prosthetic going forward, the Stickler syndrome itself does not really impact that. It's really kind of finding the right the approach to treat it, either removing the contents of the eye, removing the eye, and finding the right subspecialist to do the prosthetic fitting and building the prosthesis. I suspect the person who's asking this question has had experience with this, and they would probably know that this is not something that's done everywhere. It's a very specialized treatment that would require going to just a few centers around the country to do successfully. All right. The other one question is, can glaucoma be detected in early stages? Yes, the answer, yes, it can be detected. Now, the way we detect glaucoma, we can do multiple. So one is checking eye pressure. And then the other one we do, like in adult patients or older shrinkage children, we can do visual field testing. We can't do that in young children because it's not something they can sort of perform adequately for us to test that. We can do some other imaging to detect glaucoma, but yes, glaucoma can be detected at very early stages. Now, there are certainly glaucoma doctors who specialize in only pediatric glaucoma, and there are other glaucoma doctors who see both adult and children, and the glaucoma doctors who will not, who don't have a lot of experience in seeing children. So I would make sure that you're working with someone who's comfortable with the diagnosis and treatment of glaucoma in a child. How likely is disfigurement from surgery to reattach retina? How likely is it now compared to 45 years ago? So it's quite unlikely the eye would look different after surgery. The techniques we use now are minimally invasive, minimal sort of manipulation on the outside of the eye, and then we sometimes don't even use sutures. The wounds are self-sealing. So a lot has changed, and we have much better tools and technology since compared to 45 years ago. So it's quite unlikely that this will be a disfiguring surgery. I've never seen that. And the only time that I think, maybe something close to that is if the eye does not respond to surgery after multiple surgeries, the eye can lose its, pressure, can start getting smaller, and then to an end stage where you start developing a blind, painful eye. That could certainly, the anatomy in that case can look different. But again, quite unlikely. Does Stickler syndrome increase the risk of recurrent corneal abrasions? I have not personally seen that. I do certainly have patients we haven't even talked about that. I have multiple patients who have corneal issues. Um, because of the high myopia, you can sometimes develop something, the cornea can actually develop other conditions that can cause um, kind of cloudiness of the cornea, calcium deposits of the cornea, which the calcium deposits itself can sometimes lead to corneal abrasions and discomfort. And certainly have multiple patients with that. With those, what we do is I typically work with a cornea specialist or one of the pediatric ophthalmologists comfortable with treating this condition, and we can remove the calcium deposit in an operating room setting. And we sometimes have to do that, every once in a while, and to remove the calcium deposit to improve vision as well as to reduce any discomfort. How does the laser photocoagulation work, and what considerations need to be taken in doing this in the young children whose eyes will still grow? Excellent question. So typically, the treatment we recommend between about anytime after 2 to 3 years of age, partly because the eye basically stops growing. The majority of the eye growth happens by age 3. The eye will still grow, but really by age 3, it's reached to a size where it's almost close to it's very much close to its near adulthood size. So the growth of the eye by itself does not really impact what we need to do when we do the laser photocoagulation. Now, but it is something that we certainly will monitor. We do the laser photocoagulation as a preventive treatment. As the child grows, we continue to monitor them. And then if they're, with the growth, if there are new areas of concern appear, which sometimes can happen, you can get some thinning of the retina. So you can get something called lattice degeneration, which increases the risk of retinal tears or detachment. We will go ahead and then repeat the laser treatment. Now, in some Stickler patients, not most of them, but some, and I have multiple of them, they will require laser multiple times. I have patients who've had laser treatment, you know, 5, 10, 20 times because we have to go back and then redo laser. Because of, part of it is because of eye growth, part of it is that they develop new areas which will require treatment. So again, one of the most important things we recommend to the families is that and we discussed, this is not a one treatment and done. This is a lifelong problem that will require lifelong monitoring. With children, I typically will see them every 6 months until they're old enough that they can sort of tell us if there's a problem, and then we go to once a year. Even with my adult patients, I will see them once a year because often what we can do is with this close monitoring in clinic, we can detect problems before they become symptomatic. And if we see them and treat them early enough, we can prevent a lot of the downstream complications that can arise.
That was fabulous. I know we have so many more questions. We probably could do another hour, but we're not going to. Thank you so much for answering all those questions. I apologize for not being able to moderate. Again, I don't know
Oh,
why.
it's okay.
There's no storm here. This is South Florida. This stuff happens. So thank you so much for your time. And thank you to everybody for your questions. I'm going to put up this URL right now for you all. So you can see this. So this is our Help and Resource Center. Stephanie is our nurse, that's the director, and there's the URL. So if your questions were not answered here today, feel free to submit them through that website. And that's really the fastest way to get them answered. If we don't have the answers in-house, we'll go to doctors such as one we have tonight who will try to help us answer some of those questions. And I can tell you that based on the interest that you guys had tonight and all the questions, we'll definitely be doing another webinar on this in the fall to talk about the eye issues, different kinds of surgeries, and answering your specific questions. So so this is just the beginning. So be prepared for more from us. I also wanted to, let's see, remind you all that we do have some basic information about Stickler syndrome on the Marfan website. We are going to be working a lot more on this to provide more information for you as we get to learn more about Stickler syndrome while we learn to meet more experts and hear your stories and what you would like to, what kind of information you actually need and what's missing. So, but we also have on our website things that are appropriate for all our conditions, things like our virtual support groups. And we are starting a virtual support group on Stickler syndrome this summer. We have our Walks for Victory, where there are community events all over the country. We have like, I think, 11 or 12 of them left this spring. So that's on our website as well. We have Stickler teams at some of the walks already. So that's very exciting. I know we had a big representation in North Carolina over the weekend. So there's a lot of stuff going on with the foundation, and we hope that you'll be involved with that. Um, as I mentioned, the Stickler support group starts in July. And so we urge you to get connected to us through our email. And I will be putting up the link soon so you can subscribe to our email. Here's the conference we've talked about already. There will be some Stickler specific medical workshops, a Living with Stickler Syndrome support group, and their quality of life workshops that will be of great benefit. A lot of people come for the information and they get a lot of great information, meet experts, but the added benefit is meeting everybody else who's on a similar journey, whether they have a Stickler or Marfan or Lowy Seeds. You're faced with genetic conditions that are lifelong and dealing with families that are affected. So there's really a lot of benefit to that. Um, and and what we do is we share stories. And it's very therapeutic for people to share their story. You're teaching other people, and it's great to learn about other people who are going through what you're going through. So we do that for VEDS, we do it for Marfan, we do it for Loeys Dietz, and we'd like to do that for Stickler as well. So there's a URL on the screen that you can go there and submit, or you could submit some information, and our marketing team, our crack marketing team, which is amazing, will reach out to you. Or you can email us at brandcoms@marfan.org and let them know that you'd like to share your story about Stickler. I'll leave this up here for a minute. If you want to scan this QR code, you can then sign up for our emails. And we specifically ask you what you're interested in. And so you'll only get what you're interested in, which will be Stickler syndrome. It's based on your condition connection. So by signing up, you will get what you're interested in, not everything. So we do urge you to do that. And there is my email address. And so I do want to hear from you. I'd love to know, what else you'd like from the Marfan Foundation in terms of Stickler syndrome. We will be sending out a survey, so we do urge you to fill that out. Your feedback is important, and that helps us build the program because it's going to be for you. So, thank you all for coming tonight. Michael, do you want to say something before we close here tonight?
Well, number one, thank you. Thank you for a wonderful presentation. I must say you're the best interviewer presenter I've ever seen. Asked yourself questions and then gave the answers. I mean, you have a future just helping us out with these. So,
Thank you,
but
Michael.
but anyhow, thanks for stepping in and managing that aspect. And Eileen, we did have a quick question about will there be Stickler related physicians at conference?
Yes. So what I learned today is that we do have some eye specialists, some ophthalmologists who are going to be at our health fair at the conference, and we're checking with them to make sure that they have some expertise in Stickler. We obviously have geneticists there as well. I don't know if we have the other specialists covered at this point, but in terms of the eye, which I think from what I've learned the last several months from the Stickler community is that is the biggest thing. So we are checking with a couple of the ophthalmologists that we work with who are going to be there to make sure. And I will let you all know. I know who's registered here, so we'll let you know what's going on. Again, follow the Marfan Foundation on Facebook. We're also involved with some of the other Stickler Facebook groups. I've gotten to know some of the moderators there, and we'll share information there as well.
And Eileen, would you put up the QR code one more time?
Sure. Let me go back there. There you go.
That's it.
There
Thank
we
you
go.
all very
So,
much.
Dr. Besirli, thank you so much for your time tonight. We appreciate it. You will be hearing from us more. We loved your presentation tonight, and thank you so much for jumping in and helping us out with this.
Absolutely. Thank you. My pleasure. And I look forward to working with you guys more.
Great.
Thanks
Thanks so
very
much.
much.
Have a good night, everybody.
Bye,
Good night.
everyone.
Take care.